I am Gagana Bellari, manager at Mediversal Academy, and I'm excited to introduce our speaker, Dr. Uday Kumar Sonnappa. With over 8 years in dermatology, cosmetology, and hair transplant surgery, Dr. Sonnappa is a consultant at Narayana Hridayalaya and Wellness Champion Hospital in Bangalore. As the director of Dr. Uday's Advanced Skin and Hair Clinic, he has made significant contributions to dermatology. Dr. Sonnappa's expertise includes dermatosurgery, acne surgery, vitiligo surgery, lasers, aesthetic dermatology, hair transplantation, pediatric and geriatric dermatology, and sexually transmitted disease. He completed his MBBS in 2015 from NTR University, Andhra, and MD in dermatology in 2018 from Rajiv Gandhi University of Health Sciences, Bangalore. In 2019, he furthered his skills with the Dermatosurgery Fellowship FRGUHS from St. John's Medical College, Bangalore. Dr. Uday Kumar Sonnappa brings a wealth of knowledge to our webinar, sharing insights on severe cutaneous adverse reaction to drugs. Join me in welcoming Dr. Sonnappa. Thank you. Over to you, Dr. Uday Kumar Sonnappa. You're on mute, doctor.
Thank you, Gagana.
Thank you, sir.
So, without any further ado, we'll get to the subject prop.
Yeah.
So, a very warm welcome to all of you all, and a warm greetings today's evening session. So, like to start the session with the quote: "Knowledge is power." So, for us doctors, unless we do not enhance this thing, there's always a downgraph. So I here present a topic which is pretty much in trend, severe cutaneous adverse reaction, like the word says severe and adverse. So quite commonly people assume that dermatology is all about aesthetic cosmetics. So I had a friend very long ago who said dermatology is just giving two creams and powders and things. So here I would like to present to you all that dermatology also has emergencies, dermatology also has deaths recorded, and this presentation is an ode to that. So today's session, I would like to divide into two parts. One, I'd like you all to understand what is adverse reactions, the statistics of the same, history, the types of adverse reaction. Then I'll give you a small introduction into cutaneous reactions. Then we get to subject proper, that is severe cutaneous adverse reactions. So I begin the session here. So what is an adverse event? So, an untoward medical occurrence that may present during the treatment with a pharmaceutical product, but which does not necessarily have a causal relationship with this treatment. Just as a gist, so any occurrence that is happening in the hospital or in a clinic practice may not be directly involved with the drug that you have given. It could also mean any due outcome of the treatment process leading to any reaction. Further, WHO defines adverse drug reaction as any noxious change which is suspected to be due to a drug, occurs at doses normally used in man, requires treatment or decrease in dose, or indicates caution in future use of the same drug. Therefore, an adverse reaction is an adverse event with a causal link to a drug. So I'd also like to say something here. So just because we have accidents on the national highway doesn't mean we do not take our vehicles out. So the only thing that I want you all to infer from this is, yes, all those drugs that we use have got some adverse reactions, but use them with caution. Also know how to prepare yourself for that adverse reaction.
Doctor, excuse me. I'm sorry for
Yes,
disturbing
yes,
you.
yes.
Can you please reshare your screen once again? It has not been shared actually. I'm sorry to interrupt you in
No,
between.
no problem.
Yeah. Thank you, doctor.
No, okay. So going further, visible? Gagana, is this visible?
Yes, doctor, it's visible.
Yeah. So further, just to give you all a small introduction of the history of adverse drug reaction. So the first reported case was in 1922, which was associated with salvarsan, an organic arsenical used in the treatment of syphilis, which resulted in jaundice. Then later in 1937, elixir of sulfonamide that contained solvents, diethyl glycol also was seen, which resulted in death of 107 patients. That's when a committee was formed and decided to, monitor all the drugs which are going into market. So which we call as FDA or Food and Drug Administration, which we all follow very severely and monitorly. So also we know thalidomide. Thalidomide was quite commonly given in dermatology also until we realized there are teratogenic effects of it. The first reported case was in 1957. So in 1968, WHO program was established, which included a 10-member states of international ADR terminology, and a drug dictionary was put into being. Later, the definition of adverse reaction was coined in the year 1969, and operations transferred to Uppsala from WHO, that is Geneva, for setting up of a off-relation database management where people could put up their grievances. So in 1901, WHO came up with a database which would aid in pharmacovigilance and other resources which would help in forming a drug formulary. In 2001, there was a Viga-based online project. In 2010, the 100th country joined the WHO program for international drug monitoring. So the commonest site of drug reactions in a human body, where the green signifies rare events, the yellow signifies common events, and the pink signifies most common events. I also like to bring to your notice that whenever the green and the purple areas are involved, it means it's a severe reaction, which I would like to touch upon on my later slides. So bringing to all the statistics, the most common cause is iatrogenic, that is because of a drug. There is 3 to 5% hospitalization due to severe reaction, resulting in about 3 lakh hospitalization annually. And once hospitalized, there is 30% chance each patient can develop adverse reaction, and the risk increases by 5% each time. So just a gist of this, that each time a patient goes back into a hospital, his chance of developing a severe reaction increases every time by 5%. So the factors affecting adverse drug reactions: age, sex, genetic influences, concurrent diseases, which include your other comorbidities involving renal system, liver system, cardiac system, previous adverse reactions, compliance with dosing regimen, total number of medications, and miscellaneous causes like diet, smoking, and environmental exposure. Children are often at risk because their capacity to metabolize a drug is usually not fully developed. Children less than 18 may be at risk of developing Ray's syndrome if given acetylsalicylic acid or aspirin while infected with chickenpox or influenza. So, ADRs, including drug interactions, are common cause of admission to hospitals in the elderly. Then reactions of ADRs in the elderly concomitant with use of several medication. Their decreased drug administration. ADME stands for absorption, distribution, excretion, and medication activity due to age. These conditions are exacerbated by malnutrition, dehydration, which are quite common in the elderly. Pregnancy, like we all know, the dictum is to avoid as many as less drugs possible. Sulfonamides are known to cause warfarin, lithium are all equally teratogenic in nature. Breastfeeding also need to be administered with a caution, especially antivirals, anti-neoplastics, and the skeletal muscle relaxants. Factors affecting drug reactions. This depends on dose, duration, toxicity of the agent, dynamics properties of the agent, and pharmacokinetic properties of the agent. So genetic basis, usually atypical pseudocholinesterase is caused by faulty hydrolysis. It is seen in autosomal recessive genes. Similarly, hydrolex polymorphism, it is an autosomal recessive gene which leads to phenytoin toxicity. So we have acetyl status, which is again an autosomal recessive thing, in which fast acetylase, when isoniazid is given, acetylhydrogenases results in hepatotoxicity. G6PD deficiency, which is an X-linked recessive disorder. It is common in primaquine, sulfonamides, nitrofurantoin, which leads to hemolytic anemia. I'd like to mention a special reason here, so especially concerning to my department. So there is a pre-anesthetic cream called Top Lab, Prelox, or anything. So most dermatologists use this as a cream before doing any procedures like electrocautery or laser. So this cream is linked, especially the lidocaine is linked with G6PD deficiency in individual can lead to hemolytic anemia. So the drug should be used with a caution. Then uroporphyrinose synthetase enzyme deficiency is an autosomal dominant required for heme synthesis. This is commonly associated with barbiturates, phenytoin, carbamazepine, which give rise to acute intermittent porphyrias. So the types of ADR are broadly classified from A to F as augmented, bizarre, continuous, delayed, ending of use, and failure of efficacy. So type A, the augmented, are usually predictable ones. Type B are unpredictable ones. These are expected and are based usually of the pharmacological properties of the drug. They are more common, usually dose related, include side effects like secondary effects, toxic effects, consequences of the drug withdrawal. Whereas type B is quite undesirable, peculiarities on patient. They are less common. They are not related to the amount of dose. They are more serious and requires drug withdrawal. It includes hypersensitivity, allergy, and idiosyncrasy. Based on the onset, they are divided into acute, subacute, and latent, where acute is about 60 minutes, subacute falls from 1 to 24 minutes, 24 hours, and latent is more than 2 days. The severity of ADR ranges from minor to lethal, where minor doesn't require any treatment, can be dealt on a OPD basis. Moderate requires treatment with change in treatment and prolongation of hospital stay by at least 1 day. And severe requires intensive treatment, also results in life-threatening permanent damage, where lethal could be directly or indirectly result in death of the patient. FDA defines serious ADR as which results in death, life-threatening, require hospitalization, prolonged hospitalization, cause disability, cause congenital anomalies, require intervention to prevent permanent injury. So the pharmacological properties of a drug which result are extension of effects, quite commonly benzodiazepine, furosemide, heparin, warfarin, insulins. The adverse effects, uh, which are predictable dose-dependent reactions unrelated to the goal of the therapy, often produced by the same drug receptor interaction, possible for the therapeutic effect, differing only in the tissues or organs affected. The examples of adverse effects are isoniazid, rifampicin, quite commonly in anti-tubercular drugs, streptomycin resulting in ototoxicity and nephrotoxicity, nitrates resulting in headache, tetracyclines resulting in hypoplasia of the teeth. The type B reactions or bizarre, usually they are abnormal effects unrelated from the drugs, known pharmacological actions. The example of, again, bizarre reactions include hypersensitivity reactions, SJS, and hemolytic anemia. Type C reactions, they include ethambutol, which results in retinopathy, NSAIDs, which results in nephrotoxicity. Type D reactions are delayed. They are carcinogenesis or tetrogenesis. Example, thalidomide, which results in phacomelia. Type P reactions, these are withdrawal syndromes. Examples in benzodiazepines, which results in rebound insomnia, clonidine, or corticosteroids, which results in acute adrenal insufficiency. Type F reactions or failure of efficacy, these are counterfeit medicines, underdosing of medications, or drug reactions. Adverse reactions may be categorized into therapeutic dose, like as in atropine giving as a pre-anesthetic medication resulting in dry mouth, codeine resulting in constipation, minoxidil resulting in antihypertension, but results in hypertrichosis and male pattern baldness, or codeine used in travelers' diarrhea. Secondary effects, which have an indirect consequence of primary action of the drug, like in corticosteroids, which decrease the immunity in latent TB activated, tetracycline, which decrease the bacterial flora, which results in superinfection, the toxic effects, which cause exaggerated from the side effects due to overdose or prolonged use. These include high dosing heparin, which leads to bleeding, prolonged use of streptomycin, which leads to ototoxicity or nephrotoxicity. Allergy or hypersensitivity, this is something common that most of us come across on our day-to-day lifestyles or in our practice. So immunologically mediated allergic responses occur when sensitized individuals are re-exposed to the same drug again. So these are classified into humoral and cell-mediated. Humoral include type 1, 2, and 3, where cell mediators is type 4 reaction. So type 1 is anaphylactic reaction, which is due to IgE antibodies, and they present immediately or within 2 to 3 hours of exposure. They are urticaria, angioedema, and anaphylactic shock. Type 2 are cytolytic reactions due to antigen antibody complex, which develop within 72 hours of exposure. This includes hemolytic anemia and SLE. So an anaphylactic reaction, when the antigen is presented to the B cell, this in turn triggers the IgE cells. These IgE cells bind to the mast cells or the basophils on subsequent, so this sensitizes the cells. So on subsequent exposure to the same antigen, the antigen bridges the gap between the two antibody molecules. So thereby causing degranulation of the cell, and this causes the release of histamines and other mediators. This histamine increases the permeability and distension of capillaries. Histamine is the reason why we have itching. And that's why an antihistamine is given, which tries to suppresses the histamine. So type 3 reaction, this is called retarded or Arthur's reaction. It's an immune complex mediated reaction. It starts anywhere between 72 hours to 1 to 2 weeks from the point of exposure. The examples include serum sickness, pancytopenia, Stevens-Johnson syndrome, prosenamide-induced systemic lupus erythematosus. Type 4 is usually delayed hypersensitive reaction, and the examples include contact dermatitis. The idiosyncrasy, or these are something that is genetically determined abnormal reactivity to a chemical. Here, the drug interacts with some unique features of individuals not found in majority of the subjects. These include barbiturates, which result in excitement and mental confusion in some patients, chlorpheniramine, which results in aplastic anemia in some patients, quinine or quinidine. This results in cramps, diarrhea, purpura, asthma, and vascular collapse. Drug intolerance, these include characteristic toxic effects at therapeutic doses. This converse of tolerance increases the sensitivity to low doses. Example include trifluoropromazine, which results in muscular dystonia. Photosensitivity, again quite a common event that we see. These are cutaneous reactions in sensitized skin because of UV radiation. There can be phototoxicity or photoallergicity. Phototoxicity is a drug or a metabolite accumulates in the skin. This further absorbs light, and there is a photobiological reaction that happens, resulting in erythema, edema, blister. The wavelengths that include UVB usually, more common with tetracyclines or the other drugs, doxycycline or your retinoids. These trigger phototoxicity. And photoallergy, here the drug or metabolite is present to do the cell-mediated immune response. On further exposure to UV light, there's a papular or erythematous contact dermatitis like pictures. This is quite common with UVA rays. These happen on sulfonamides or griseofulvins, and griseofulvin was a common drug given as an antifungal agent. Drug withdrawal reactions. Sudden interruption of drug results in worsening of clinical condition for which previously drug was used. Quite commonly seen in clinical practice with corticosteroids. So as long as we give corticosteroids, the symptoms are all under control or masked. Once you stop, it all flares up. And again with beta blockers, again given in hypertensives and other medical ailments, it causes worsening of angina, precipitates myocardial infarction. teratogenicity, that is when a drug is given to a pregnant mother, it results in fetal abnormalities. Quite commonly that we have all learnt is thalidomide, which result in phacomelia, that is shortening of limbs. Diethyl espistrol, which results in vaginal adenocarcinoma. Valproic acid, which results in neural tubal defects. Anti-thyroid drugs, which results in fetal goiter and hypothyroidism. Phenytoin, which results in cleft lip and microcephaly. Drugs can affect the fetus at three stages. One at the fertilization stage, or the organogenesis state, and later at the growth and development. The carcinogenicity and mutagenicity. Carcinogenicity is usually oxidation that results in reactive metabolites, which causes structural gene damage. These are quite common with anti-cancer drugs or when estrogens are given. Mutagenicity, these are structural changes in the DNA where the oxidation of the drug produces reactive metabolites. These are inheritable, takes 10 to 40 years to develop, quite common with anti-cancer drugs, radioisotopes, or usually marketed for life-threatening conditions. Iatrogenic or drug-induced diseases, these again are quite commonly used drugs which result in these NaCH, which results in peptic ulcers, hydralazine, or phenothiazines, or isoniazides. Drug dependence. Use of drug produces a state in which person believes that continuous use is necessary for state of well-being or to avoid withdrawal symptoms. There are two ways. One is psychological, the other one is physical. Psychologically, here the person believes that the state of well-being is achieved only with the action of the drug. That is someone who's developed dependency for opiates and benzodiazepines. Physical, here there's a repeated admission of the drug required to maintain physiological equilibrium, which discontinuation leads to withdrawal. This is again with alcohol, barbiturates, and benzodiazepines. So, couple of points which will help us prevent adverse drug reaction. Try to avoid inappropriate drugs. Use appropriate dose when needed. Elicit and take into consideration previous history of drug reaction. Rule out other allergic diseases and exercise caution. Rule out possibility of drug interactions. Adopt correct drug administration techniques. Carry out appropriate laboratory investigations when needed. Be aware of the interactions with certain foods, alcohol, and even household chemicals. So when there's an ADR, discontinue the offending agent. It can be safely stopped. The event is life-threatening or intolerable. There is a reasonable alternative for all drugs. Continue the medication till further it exacerbates the patient's condition. Continue the medication, modified if needed. If it is medically necessary, there's no reasonable alternative. The problem is mild and will resolve with time. Discontinue all non-essential medication, administrate appropriate treatment, consider a re-challenge or desensitization. This includes a drug challenge test where a given drug is divided into 4 parts and the 4th part is given under a conducive environment where you're trying to challenge the drug. In case of an adverse reaction, have a backup to control the event. So quite commonly, we've already discussed earlier, the pharmacologically predictable drugs are phenytoin, digoxin, indomethacin, nortriptyline, lithium, non-steroidal anti-inflammatory drugs. So unpredictable toxic effects can happen when, which is dose independent, and less than therapeutic dose may lead to toxic effect. With this, we go to subject proper. Severe cutaneous adverse reaction. First, what is cutaneous reaction to drug? These include 2% of all OP patients and 5% of IP admission. In OP, we would see quite commonly urticaria or hives at present when a drug is not accepted, or patient could also present with itching. There could be a lot of discomfort. Some also come with heaviness of the chest. Some come with breathing difficulties. Some come with swelling of the lips also. Approximately 2% of all drug-induced skin reactions are considered serious according to the WHO definition. If it results in death, requires hospitalization or prolongation of existing hospital stay, or it results in persistent or significant disability or incapacity or is life-threatening. This is the WHO definition of serious. So mechanism of cutaneous drug reaction, like we have already discussed earlier, is classified into immunologic mechanism, which is unpredictable, non-immunologic mechanism, which is predictable, idiosyncratic with a possible immunomechanism, which is unpredictable. So we'll be touching upon the usually the unpredictable side effects, quite commonly DRESS, TN or SGS, drug reactions, induced lupus erythematosus. So starting with Stephen-Johnson syndrome or toxic epidermal necrolysis. So it's a severe mucocutaneous reaction, that is where it involves the mucous area and also the skin. Mucous area could be the eyes, lips, nose, even the internal conjunctiva of the eyes also. It is characterized by a blister and epithelial sloughing, that is the skin being peeled out. Two terms, that is in a single severity spectrum. SGS is less extensive, whereas TN is more extensive. There are 1 to 2 cases per million every year, quite commonly in elderly females. There's an increased risk of SGS-TN in HIV infected individuals and possible association with SLE. So quite commonly, it is always a drug, and to a lesser extent in non-drugs and sometimes in mycoplasma pneumonia. The genes vulnerable for this are HLA-B1502 and HLA-B5801. Most common drugs includes allopurinol, carbamazepine, lamotrigine, nevirapine, oxycam, phenobarbital, phenytoin, sulfamethoxazole, and sulfasalazine. The pathophysiology includes MHE class 1 restricted drug presentation leads to clonal exposure of CD8 plus CD cells, which in turn triggers TNF alpha and interferon gamma, which results in oxidase synthesis. And there is a lot of immune response leading to keratinocyte damage. So this is bound by fast ligand, perforin, gran enzyme, granulosin, which further add in triggering the keratinocyte death. The clinical features in cutaneous infection includes latency, that is 7 to 8 days from the administration of the drug. The prodrome symptoms include malaise, fever, upper respiratory tract symptoms. The rash are atypical target-like or purpuric macules. They start on the face and chest and then disseminate everywhere. They present either as vesicles or fluid-filled blisters which develop within a lesional skin. There are large areas of confluent erythema which may develop. There's a special sign that we all have to demonstrate, something called Nikolsky's sign. It's a gentle lateral pressure which causes lesional epidermis to slide over the dermis. That is, you at the side of the blister or on a bony prominence, you try to pull the skin back. When this is done, it talks about the severity of the disease or if the disease is in its active state or no. So when the skin is peeled easily, it means the disease is active. So toxic epidermal necrolysis, here the photograph of a patient showing redness and the darkening of the skin and few maculopapular rashes on the arms. So there is quite larger slugging of the skin, which necrosis also showing. The black skin shows necrosis. So here we have got another photograph. The one A is of SGS, the one picture B is of TN. Here, the characteristic dusky red color of the early macular eruptions in TN, lesions with the color often progress to full-blown necrolytic lesions with dermoepidermal detachment. B shows positive Nikolsky sign where there is epidermal detachment produced by mechanical pressure on the area of erythematous skin. So again, further pictures being shown where clinical features of toxic epidermal necrolysis, there's a detachment of large sheet of necrolytic epidermis leading to at least involvement of more than 30% body surface area. There's also leading of extensive areas of denuded skin. There are hemorrhagic crust on the picture B, that is along the angle of the mouth where the tubes are going. There you see hemorrhagic crust with mucosal involvement, and C shows epidermal detachment of palmar skin. So if you all remember the very first slides when I showed the most common sites involved or rare sites, when you see the rare sites, it shows the hands, the scalp and all. So the severe forms are always SGS and TN, which involves the palms and the head. So these are quite fatal. So we've got atypical target lesions. These are red macules which has a dark center and a slightly paler outer ring. Why they are called atypical is this has to be differentiated from another serious event called erythema multiforme. Here you have a dot, a red dot surrounded by a halo around. So it pretty much looks like a dart board or the bullseye where you have a pin in the middle where the darts are put, and around it you have concentric rings. So you have purpuric macules, that is a flat lesion, and the fluid filled you see is a blister.
Doctor, your screen is not visible.
One second, I'll try to share again. Visible now?
Yes, doctor.
Yeah.
Yes, sir.
So sorry for that. Yeah. So now we are also showing another photograph in conjunction to SGS and TN. Again, there are furthermore atypical targets on the palms and soles with blistering. So again here tiny, the red ones you see, they're all blisters forming both vesicles and larger flaccid bullae. The picture A, the above one, shows all vesicles, whereas the picture down shows large flaccid bullae. Here is a picture again showing confluent erythema with negligible blister somewhere on the upper back, and there is epidermal detachment also somewhere on the upper back. So this is a typical presentation in TN where there is skin slugged off, there is necrosis. The black pigmentation that you see is not the color of the patient, that is the skin getting necrosed. So these are quite common areas again present, leading to detached epidermis. So the clinical features include usually the mucous membrane, that it involves the eye, where there is visual impairment, conjunctivitis, pseudomembrane formation. There is corneal and conjunctival epithelial defects. Mouth has an erythema with blister and ulcer formation, leading to hemorrhagic crustings. The tongue and the hard palates are common sites, and also urogenital tracts are involved, which results in dysuria, urine retention, mucosal erythema, blistering, and erosions. Lungs also leads to dyspnea, increased respiratory rate, and bronchial hypertension. So this is again a classical picture of a woman showing conjunctivitis. Also, there is keratitis with purulent discharge, where the green material is exudate stained by fluorescent dye. So lip involvement, where there is severe cheilitis, has produced thick hemorrhagic crust. So, and confluent erythema of the scrotum and discrete lesions on the glans penis. So differential diagnosis includes the other severe reactions. Quite commonly, like I said, the target lesions, which also is present in erythema multiforme major. Blisters are present and skin peeling is present in pemphigus vulgaris. Membrane pemphigoid, a variation to pemphigus, where it involves the oral or mucosal areas. Bullous pemphigoid, which usually presents in the elderly, that is in the 5th and the 6th decade, where there are tense bullae which present with itching. Paraneoplastic pemphigus, you'll always have to rule out other internal organ involvement with them. Bullous lupus erythematosus, these are quite commonly on sun exposed area where they have phototoxicity also. Linear IgA bullous dermatosis, they've got two variants, one in the adult and later in the childhood form. They have pretty much tense blisters present, only diagnosable on histopathology. Then generalized bullous fixed drug eruption, acute bullous graft versus host disease, which happens in when there is a transplant that has taken place, and staphylococcal scalded skin syndrome, quite common in the pediatric age groups. Acute generalized exanthematous pustulosis. This is again a very common event present with drugs, quite commonly mistaken for prickly heat or sweat boils, which we call, which are present on the back. But this always happens on administration with a antibiotic drug. So caution should be exercised. So the severity is classified based on the involvement, 10%, 10 to 30%, and more than 30%. When toxic epidermal necrolysis without spots and there's detachment greater than 30% BSA with loss of larger epidermal sheets without purpuric macules or target lesion, the prognosis is quite poor. So acute complications include hypothermia. The reason being that the skin has lost its blanket, that is, the skin has been slugged off. So there is no thermoregulation between the core temperature and the outside temperature. There could be anemia and leukopenia for the same reason. Since the skin barrier is disrupted, there is bleeding also. There is facilitation of external infections also. And fluid electrolyte imbalance, acute renal in shutdown, high output cardiac failure, there's dyspnea and hemoptysis, and septicemia. Chronic complications include that are because of related to skin, post-inflammatory dyspigmentation. These are all of least concern. Once the patient recovers, these things are quite commonly seen. PIH or eruptive melanocytic nevi or telogen effluent, that is chronic loss of hair. Eye, there is corneal and conjunctival ulceration and scarring. There's a dry eye, entropion, and trichiasis, that is losing of the eyebrows, eyelashes. Lungs lead to bronchiolitis obliterans. GI system includes esophageal strictures because of ulcers. Gynecological, there's again because of vaginal and introital adhesions. Psychiatric, the whole process being very traumatic leads to post-traumatic stress disorder. Most common life-threatening is septicemia, and most common related to mucocutaneous is the ocular. So there's a common grading system used, first devised for TN, but quite commonly also used in burns patients called Scotin, where there are some diagnostic parameters that has to be assessed. This gives us the prognosis of the disease. So there are 7 parameters. For each, 1 point is given. Higher the score means higher the death rate. These include age more than 40, history of malignancy, heart rate over 120, epidermal detachment more than 10% of the body surface area at admission, serum urea of more than 10 millimoles per liter, serum glucose more than 14 millimoles per liter, bicarbonate levels less than 20 millimoles per liter. Body mapping is important. So body surface area is calculated for the extent of erythema and epidermal detachment. So Wallace rule of 9 is used. That is, your thumb is used as 1%. So you try to map based on that. So here there's a photograph showing the commonest sites involved in different patterns. The first one being SGS, the second being SGS TN overlap, and the third one being TN. So what specifically I want you all to see is when it involves the palms and the scalp, it's always a severe drug reaction. Right. So the first one, the surface area is 10%. There are only islands of skin that are involved. Whereas in the SGS-TN overlap, they are more confluent and they're beginning to spread. And in over 30%, that is in severe TN, there are large areas of skin involved. So the investigations are done to, one, substantiate the diagnosis, exclude other blistering disorders, and identify any systemic complications. Test at presentation requires CBC, RFTs, your LFT, bicarbonates, glucose, ESR, C-reactive proteins, mycoplasma serology just to rule out a possibility of infection, complement test, and indirect immunofluorescence to rule out other blistering disorders. Skin biopsy helps us in giving other blistering disorders. Always for histopathology, you need lesional skin adjacent to the blister. That is, when there's a blister is there, you do not take the blister alone. You take a skin at the margin, the blister and the normal skin. For direct immunofluorescence, you need a peri-blister lesional location. That is a lesion next to the blister without taking the involved skin. Chest X-ray is also needed to rule out any edema, pulmonary edema, fluid overload. So this is the histopathology from coming from above down. What you see like a lazy pattern or more of a sorry. So more of a the mountain ranges, that is the epidermis loosely spaced, and as you go down to the deeper structure where you see lesions in vascular way. So these signify accumulation of a lot of inflammatory cells. So there is parakeratosis, there is subepidermal cleft, civet bodies, superficial perivascular infiltrate. Management of SGS includes first identifying and stopping the offending drugs. This pretty much holds good for all the other drug reactions also. Meticulous care of lesional skin and mucous membrane, intense supportive care of the systemic complications, and initiating specific therapy. That is, this includes symptom-oriented treatment. So if it is more than 10% of the BSA can be managed, it has to be managed in ICU or the burns unit. And because since this person's skin is denuded or there is necrolysis of the skin, patient is more prone for infection. That's why it has to be used in ICU with barrier nursing and only one patient or a nurse at a time to minimize the exposure of infection from an outside source. An ambient temperature should be maintained at 25 to 28 since there is already hypothermia. It requires a team of dermatologists, surgeons, ophthalmologists, gastroenterologists, gynecology, urology, because it involves multi-organ at a multi-organ level. First, the culprit drug is an essential and immediate intervention. All medicines taken by the patient over the previous 2 months has to be assessed. So care of skin includes one, the discharged skin is not peeled off. It is left to stay because the overhanging skin itself acts as a dressing. Topical antibiotics are given. The crusted areas are treated with adherent dressings and saline compress. When there's an intact skin, gentle irrigation with warm saline is given or chlorhexidine in a ratio of 1 is to 5,000. When there is whole skin, frequent application of aerosolite formulations are given or liquid paraffin. Care of skin and mucous membrane continued for the eyes. It has to be cleaned regularly. A lubricant is given. Antibiotic and steroid eye drops are given. Amniotic membrane transplantation for extensive loss of epithelia is considered. For mouth, regular saline is given since there is a lot of dryness. Antiseptics are given to prevent secondary bacterial infections. Mucoprotectants are given. Steroid mouthwashes are given. The reason being, the patient will have a lot of inflammation. So patient will not be in a position to take anything orally. So quite commonly what we give is, we ask a combination of Gelocil, combination of uh, omnocotyl syrup, just to take about 2 to 5 ml and swish in the mouth, like how we ask the patient to mouth gargle. The same thing is done in the mouth and the patient has to spit out. This gives a lot of positive input. It reduces the pain and erythema. So frequent water solution are applied. Then urogenital tract catheterization is definitely needed and care also is to be emphasized. Frequent use of ointments are needed. Silicone sheet dressing to eroded areas are needed. Topical steroids with antibiotic activity to non-eroded areas are also given because steroids here only as anti-inflammatory. It reduces the inflammation to great extent, giving patients some relief. Supportive care includes fluid replacement. I'm sure most of us have heard of Parkland formula, that is IV crystalloids or ringer lactate are given at 4 ml per kg body weight with the percentage of body surface area involved in the first 24 hours. Later, half the volume is given in 8 hours and the remaining volume over the next 16 hours. The urine output should be maintained at 0.5 ml per kg per hour. Nutrition is always enteral or parenteral nutrition. Nasogastric feeding tube with silicone tube can be given. Analgesia should be kept to bare minimum because these are also a cause, and in severe cases, opiates also can be used. Additional supportive medications include CSF transfer, PPIs for gastric protections, low molecular weight heparin for thromboembolism, and monitoring infections, blood culture, culture from the slugs and crusted sites, monitoring oxygen saturation, urine output, hypotension, and prophylactic ointments are avoided because they can increase the risk of colonization. Intravenous immunoglobulins are found to be beneficial when started within the first 3 days or the 4 days of presentation. And systemic steroids also have a lot of effect. They are given at a dose of 2 to 2.5 mg per kg daily in divided doses. Cyclosporin, which is an immunomodulatory drug, inhibits the lymphocyte function. It is given at a dose of 3 mg per kg per day. So the IV immunoglobulin, what it does is, since the fast ligand and fast sites are having a genetic implication, they cause a lot of tissue necrosis. These immunoglobulins, when given, they act as a blockage and help in promotion of the skin healing. They are given at a dose of 1 gram per kg for 3 days, usually, or there is another group, Miami group from the American Association of Dermatology, which use it as 1 mg per kg for 4 to 7 days. The disease course and prognosis, acute phase increases over the first 5 to 7 days. Then reepithelialization starts and heals by 2 to 3 weeks. So point to note here is, like I said, the earlier the treatment starts, the better it is. The 5 to 7 days that we say, usually patient starts deteriorating by that time. If active intervention and treatment is given before that, definitely a lot of healing process happens. In sepsis or systemic complication, unless the culprit drug is not removed, there is delayed wound healing. The overall mortality expected with TN is over 22%. Usually the cause of death is septicemia, which results in multi-organ failure. So this is a kid who's presented with a similar such thing. So the point of notice is the patient was given IV antibiotics without a test dose, which quite commonly happens. So why I put this photo, a young fellow suffering for someone's blunt mistake has led to this. So let's exercise caution at least from now on. So these are again HGS things with a lot of maculopapular rashes and erythema. And this is epidermal detachment in HGS. And this is a lady with large sheets of epidermis removed with the necrosis in TEN and hemorrhagic crust with mucosal involvement and genital mucous involvement. So now we move on to the next severe cutaneous adverse reaction called erythroderma. It's generalized exfoliative dermatitis, defines any inflammatory dermatosis that involves all or nearly all the skin surface. It is a secondary process and represents a generalized spread of a dermatosis or systemic disease throughout the skin. By this I mean erythroderma per se is not the primary event. It always secondarily happen to an already existing disease, like in say psoriasis or acute eczemas or atopic dermatitis, where the skin, the presentation is very mild initially, but a lapse of treatment or fault from the patient's end further expands the skin and involves a larger area. So that is involvement of more than 90% of the body area results in erythroderma. General symptoms and presentation include they are quite common in men, affect the middle-aged and the elderly, develops suddenly when associated with leukemias or eczema. Presence within 12 to 48 hours, they result as patchy erythema rapidly spread by accompanied by fever, malaise, and shivering. In 2 to 6 days, there's scaling with hot, red, dry, and thickened skin. Patient also experiences irritation and tightness of the skin and feels cold. The scalp and body hair are lost when erythroderma is been present for a larger time, that is over weeks. So this is a typical presentation in asteatotic eczema, where you see the skin in the first photograph. There is fish-like scales with a lot of scaling and dryness over the upper back. This on the second patient, the skin has begun to peel. In the third, the skin has peeled over the upper arms and the lower abdomen. You can also appreciate the redness that is involved. And here you do not see sparing of skin. It is quite confluent or they are uniform. Quite commonly, it is eczema, where atopic eczema may become erythrodermic at any age and most commonly in elder. Also, the withdrawal of potent topical steroids or of systemic steroids or incurrent drug eruption can precipitate erythrodermic psoriasis, usually presents as sterile pin-sized pustules which develop and may progress into generalized pustular psoriasis. Just a point of interest, when patient sees pustules in psoriasis, they think of giving a steroid or antibiotic. It doesn't help because these are sterile pustules, that is doesn't yield any microorganism. This has to be addressed with an immunomodulatory drug, topical creams, and saline compress. So also lymphoma and Sézary syndromes also can lead to erythroderma. Here early biopsies will help in treatment. In Sézary syndrome, it occurs in elderly males and it is characterized by presence of abnormal T lymphocytes with larger convoluted nuclei in the blood and skin. Drug eruptions, often of toxic erythema or morbilliform type, may become erythrodermic, quite commonly with carbamazepines, phenytoin, diltiazem, cimetidine, gold, allopurinol, sulfonamides are the commonest culprits. Pityriasis rubra pilaris, a disorder of unknown etiology that begins in adults, results in redness and scaling. It is a follicle-based eruption and characteristically shows islands of spring and a yellow keratotic. That is, when there's a hair follicle, it presents around the hair follicle with islands of redness with normal skin interspread between them. Complications include the because of physiological and metabolic changes, which could lead to cardiac failure, hypothermia, cutaneous or respiratory infection, edema, and increased pulse rate. The cardiac failure is because of increased blood flow and increased plasma volume. Cutaneous edema is because of increased capillary permeability, increased plasma volume, hypoalbuminemia, uh, and hypoalbuminemia is again further increased plasma volume, reduced albumin synthesis, increased metabolism, protein low in scaling, increased transepidermal water balance. Impaired temperature regulation is because of increased capillary permeability, and dermopathic lymphadenopathy is because of cutaneous inflammation and infections. Management is inpatient, it requires patient's admission and skilled nursing to be checked for regular temperature, requires warm room, regular monitoring of pulse, BP, temperature, and fluid balance. Also requires pressure relieving mattress because since the skin has become tight, requires a lot of soothing emollient creams and topical steroids. Systemic treatment includes oral administration or IV administration of steroids at 0.5 to 1 mg per kg body weight. Maintenance of normal hemodynamic attention to electrolyte and adequate nutritional support are vital for severe ill patients. Here, as a nutritional support, high protein diet is very important. Albumin infusion also does help to a great extent. So moving to next topic, dress. Um it is an idiosyncratic multi-system drug hypersensitivity disorder. It is characterized by skin rash along with systemic upset, that is hematological and solid organ disturbances. It is found in 1 in 1000 to 1 in 10,000, average age being 48, female preponderance being more than male. Drugs commonly with infection with HHV, cytomegalovirus, Epstein-Barr virus, herpes, human herpes 7, quite commonly presents with DRESS syndrome, and genetic implication which HLO-B type 5701 and HLA-B 1502 and 3101, that where it is associated with abacavir or carbamazepine. Most common drugs causing stress, again, pretty much these etiology are same for all the other reactions, but only the way of presentation varies very slightly. So like we read earlier, allopuranols, anti-epileptics, antibiotics, sulfa drugs, furosemide, omeprazole, ibuprofen. See, omeprazole is quite common drug that we all give in our day-to-day practice. It is given as an antacid or PPIs. So this is also to be exercised with caution. So the percentage of them involved, where allopurinol responds to most of the drugs which cause. Next is phenytoin, dapsone, and so on. There is heptatonization theory where immunologically neutral molecules is rendered antigen when bound to a protein. And there's a PI concept where pharmacological interaction of a drug with the immune receptor makes it vulnerable. This results in slugging of skin. Or persistence of a viral reactivation helps the chronic phase of stress. Clinical features, it takes about 6 weeks or up to 3 months for onset of symptoms. Prodrome being asthenia, that is pain, malaise, fatigue, and fever. There could be head and neck edema, which are important findings. The rashes are of usually four types. One, urticarial papular exanthem, mobiliform erythema, exfoliative erythroderma, or erythema multiforme like reactions. So the most clinical phenotype is widespread papules. These are lesions that are raised, and plaques which are more than 1 to 1.5 centimeter in size, accompanied by cutaneous edema. Mobiliform, like marble-like, the redness is less, but they're quite diffusely present. They're more of macules, that is just discoloration. Diffuse and confluent rash in a patient with DRESS. Then widespread exfoliative erythema. That is, you can appreciate the color difference between the face and the body. The redness is marked. There's erythema multiforme, like I was telling earlier, the target lesions. If you all see on the abdomen, you see some red dots with surrounding darker circles. They're all confluent. That is, they are adjoining to each other. This similar such thing is present in erythema multiforme also. But here, the patches are meeting each other, as in they're spreading to become a bigger patch. There is diffuse erythema with exanthematous eruption. There is prominent facial edema like in urticaria. And there is purpuric eruption. These that you see on figure C on the around the knee. The clinical features of mucous membrane involvement is rare. Um, there could be cheilitis, that is inflammation of the lips. Systemically, there is lymphadenopathy in at least two sites. Liver results in hepatocellular and obstructive pattern of hepatitis, most common with phenytoin, minocycline, and dapsone. There is renal dysfunction, quite commonly with allopurinol. There is cardiac complications like pericarditis and myocarditis. GI symptoms include bloody diarrhea and esophagitis. Endocrine, there is thyroid dysfunction and type 1 diabetes. Lungs include pleural effusion. pleuritis, or acute intestinal pneumonitis. CNS includes headache, seizures, and cranial nerve palsies. Dress overlap syndromes, since these features are quite common and the drugs causing also are quite common, there could be an overlap between SJS, TN, and DRESS, or acute exanthemat papulosis and DRESS also. Differential diagnosis for this includes sepsis and infection or other severe adverse reactions like AGF or SJS and TN. Diagnostic criteria for DRESS includes Registrar, where there are set points which giving a scoring of 1 point, and when it increases more than 2, the possibility of risk includes with the mobility. So first one being the extent of rash being more than 50% of the body surface area, a rash which suggests of DRESS, systemic involvement having either of this lymphadenopathy, eosinophilia, atypical lymphocytosis or organ involvement, or a relevant negative serological test. So these when where there is less than 2 points, then it is not a case of DRESS. When there is 2 to 3 points, then it could be a possible case, and when it is 4 to 5 points, a probable case. More than 5, it is definitely a case of DRESS. Poor prognostic markers in DRESS include blood markers where there's eosinophilia, pancytopenia, thrombocytopenia, lymphocytosis. Clinical markers, atypical target lesions, purpura, tachypnea, tachycardia, coagulopathies. High notoriety drugs, that is, when allopurinol and minocyclines are given, may confer a higher risk of more severe hepatic involvement. Again, I would like to stress on this point minocycline, which is again a common antibiotic given in treatment of acne. So to exercise caution and use it with precaution. Complications include liver failure, interstitial nephritis, thyroid dysfunction, myocarditis. Autoimmune phenomena may arise following DRESS, that is SLE, Hashimoto's thyroiditis, protracted clinical course which include chronic exfoliative dermatitis. Investigations for hepatic LFTs, lactodehydration, ferritin, coagulation screening, and in case of Epstein-Barr virus, check for viral serology. For cardiac involvement, look for electrocardiogram, echocardiogram. Cardiac enzymes, creatine kinase and troponin should give you a valid levels. Pulmonary, you need chest X-rays, pulmonary function test, and suspecting autoimmune related disorders, we need anti-nuclear antibodies, complement testing, anti-neutrophil cytoplasmic antibodies. Renal RFTs for neurological CT and MRI scalp, electroencephalography. In case of endocrine, quite commonly it is thyroid, so thyroid function test should help. And suspecting diabetes, blood glucose should help. Infection, cultures and mycoplasma serology, or PCR for herpes simplex virus. In gastrointestinal, test for enzymes like amylase, lipase, triglycerides, and colonoscopy. A skin biopsy gives us uh, pretty confidence, or it also tells us the prognosis of disease. Here we see basal cell vacuolation and several necrolytic keratinocytes. Treatment includes pretty much the same like any other scar disease. One is identifying and removing the offending drug, supportive care in terms of intravenous fluids, regulation, catheterization, supplement oxygen, and surveillance for coexisting infections, management of organ specific involvement sought from appropriate specialties. So talking about dermatology specifically, the first choice being oral prednisolone given at a dose of 0.5 to 1 mg per kg per day. Later, it is taped off, varying from 1 to 3 months. And cyclosporin or intravenous uh, uh, immunoglobulins are known to give a lot of valid points when administered at the initial stage. uh, and it also should be given it caution because it could cause viral reactivation. Third line is plasmapheresis, rituximab, N-acetylcysteine in severe liver involvement. The disease course and prognosis include majority will recover fully following withdrawal of culprit drugs and management of acute episodes. The organ-specific chronic sequel may arise after the acute phase. A number of autoimmune phenomena can arise after the acute phase. Now moving on to our next drug reaction. It's one of the scar syndromes. It's characterized by rapid appearance of sheets of non-follicular sterile pustules. It's usually localized on the major flexors, that is around the elbows, around the knees. It is rapid in both onset and resolution. It is usually a self-limiting phenomenon. Quite commonly, we see this or mistaken to it to a prickly heat or heat boil. So it is 1 to 5 per million per year, quite commonly in adult females. Drugs form 90% of the cases, lesserly known in Mycoplasma pneumonia, Coxsackie viruses, parvovirus, and cytomegalovirus. The other causes include mercury exposure and spider bites. Most common drugs include pristinamycin, aminopenicillins, quinolones, chloroquinone, hydroxychloroquine, sulfonamides, terbinafine, diltiazem. Terbinafine is again a common drug given in treatment of tinea or fungal infection, both in oral form and topical forms. It's usually a drug-specific CD4 and CD8 cell response. It results in high levels of CXCL8 production. There is interleukin 8 neutrophil attracting chemokines. There's interleukin 36 RN gene mutation. It starts about 2 to 5 days after the drug exposure. It presents with burning or itching of the skin. There are rashes, which results in sheets of hundreds of sterile, non-follicular pustules. Here, the word sterile refer to that when we do any culture doesn't yield any organism. So the sterile pustules are present on the background of a erythema, that is redness, in major flexures such as the neck, axilla, inflammatory, and inguinal folds. The other types associated with this are atypical target-like lesions, purpuras, blisters, and vesicle. It can also involve the mucous membrane, which is usually rare and mild. So this is how a typical acute granulomatous eruptive xanthoma presents. There is sheets of sterile non-follicular pustules on the arm. So there is pustules with erythema at the knee flexures also. You can appreciate the redness that is there and study the pustules. Quite commonly, people think it's an infection. Again, the eruptions are resolving with post-papular desquamation. That is, this is a healing phase where the patient is showing dryness of the skin and also the scales being peeled out. So this is again an acute phase where there is pustules with skin desquamation also. This is more severe form of it present on the abdomen. So clinical features or systemically could have fever, neutrophilia, agranulocytosis. There could be liver, renal, and pulmonary dysfunction. Usually resolves rapidly within days, leaving post-papular desquamation. Differential diagnosis should be one, a pustular psoriasis, subcorneal pustular dermatosis. Here the word subcorneal is a misnomer. It doesn't mean an infection of the eye. Then should be ruled out from dress or candida infections. So a pustular psoriasis presents here. If you all saw the earlier image, the pustules are minute in case of Egypt, but here they are quite large. Subcorneal pustular dermatosis, here there are islands of red skin and around it a confluent pustular edema is present. Pustular vasculitis, this is present on the thenar eminence of the skin where there is marked pus collection with a central necrosis. So, Ejeb and psoriasis, possibly a history of psoriasis should be noted. The distribution in Ejeb is predominantly in the folds. The duration is shorter. The fever is also short-lived. There is always a history of strong drug possibility. Recent drug administration is always present. Arthritis is more common in psoriasis. On histopathology, there is spongiform, subcorneal, or intraepidermal pustules. There is also edema of papillary dermis, vasculitis, and exocytosis of the eosinophils. Diagnostic criteria includes one, appearance of hundreds of sterile non-follicular pustules at the flexural sites, histopathological changes of spongiosis and epidermal pustules, fever more than 38 degrees Celsius, blood neutrophil count of over 7 into 10 to the power 9 per lakh, and there is acute evolution. A baseline investigations needed where it indicates neutrophilia and eosinophilia. Biochemical investigations to rule out renal and liver dysfunction, needs ESR and CRP, and septic screening. Like we already read about the biopsy, same two subcorneal epidermal pustules with papillary edema. Here showing us two slides of immunofluorescence where the first one, G, shows healthy skin where there is no inflammation, where Oris on the H slide shows marked inflammation with a central vacuolation where there are neutrophils in the center. This signifies a HF. Treatment includes identifying and withdrawing the culprit drug, supportive care in systemic involvement, oral corticosteroids, and emollients include continued thorough post-papular desquamation phase. The disease has excellent prognosis, which resolves quickly with discontinuation of the offending drug and resolves without sequel. Now moving to our next topic, generalized exfoliative dermatitis. It's a scar syndrome characterized by erythema, scaling affecting more than 90% of the body surface area. The incidence is between 5 and 40% of all erythroderma. It's quite commonly associated with HLA-B5801. Most common drugs being the same: carbamazepines, phenytoin, phenobarbital, allopurinol, anti-HIV drugs, anti-tubercular medications. Pathophysiology, here there is increased epidermal turnover. There's a decreased transit time, that is for the cells to come from below to above. It is a Th helper cell 1 and T helper cell 2 mediated response. There is an upregulated of CD62 cell on keratinocytes, and there is recruitment of T cells and Langerhans cells. The onset is always abrupt. There is erythroderma due to stress up to 3 months. Usually there's a rash with generalized scaling, erythema, and pruritus. Constitutional symptoms like malaise, hypothermia, and fever are present. There is lymphadenopathy, organomegaly, and there's high output cardiac failure. It has to be differentiated from other causes of erythroderma. Routine investigations like CBC, peripheral smear, ESR, CRP, investigation based on systemic involvement is needed. Patch testing for culprit drug is needed. Skin biopsy to rule out other causes of erythroderma and presence of eosinophils are needed. Treatment here includes identification and withdrawal of the offending drug, supportive management for hypothermia, fluid and electrolyte imbalance, and high output cardiac failure, antibiotics in case of sepsis, and topical and systemic corticosteroids. Has the best prognosis of all the other severe adverse cutaneous drug reactions with discontinuation of the offending drug. Anaphylaxis, this is again quite a common event that all of us experience. It's a life-threatening acute type 1 hypersensitivity reaction which results in rapidly evolving generalized multi-system allergic reaction. It includes anaphylactic and anaphylactoid reactions. There's a clinical state and treatment for each reactions are identical. Quite commonly, it could happen with anything with the environment. One is medication, food, insect stings, and idiopathic. Here, when the allergen comes in contact with the system, the immune system is triggered where the mast cells are degranulated and histamine are released. When on histamine release causes vascular permeability, resulting vasodilatation. There is prostaglandin D, leukotrienes, platelet activating factors. There is TNF alpha, which activates neutrophils and increases chemokine synthesis. Clinical features include latency, which starts within 1 hour of the drug exposure, presence with respiratory breathlessness, tachypnea and dyspnea. Cutaneous symptoms include flushing with pruritus and urticaria. CVS includes hypotension and shock. Diagnosis, it is usually clinical with two or more involved system, even in the absence of the airway involvement or hypertension. So the treatment includes airway, breathing, and monitoring. Immediate injection of adrenaline is given. If requiring multiple injections and continuous infusion of zero point 0.1 mg, IV is given over 5 to 10 minutes duration. Adjuvants like methylprednisolone can be given and antihistamines as a supportive treatment. Erythema multiforme, it's an acute self-limited skin disease characterized by abrupt onset of symmetrical fixed drug papules, some of which evolve into typical and atypical papular target lesions. The precipitating drugs are pretty much similar. In case of viral infection, it includes herpes infection, varicella, and chickenpox. Drugs include primarily non-steroidal drugs, sulfonamides, and anticonvulsants. Exposure to poison ivy also can cause. And systemic involvement includes inflammatory bowel disease, lupus erythematosus, or Behçet's disease. Clinical features here includes less than 3 centimeter in diameter, regular round shape and well-defined border, has three distinct zones: central dusky zone, surrounding paler zone, and peripheral erythematous halo. So this is our typical erythema multiforme like lesion looks, where there's a target lesion in the center with a halo peripheral rim. So again, a similar photograph here also, where confluent present on the dorsum of the hand. Last thing, fixed drug eruption. Here the drug advocates are sulfonamides, NSAIDs, and barbiturates. Here, there is onset of the eruption within 1 to 2 weeks if exposed for the first time, and within 24 hours on later re-exposure. Basically, what happens here is when a patient is allergic to a drug, the drug is first sensitized by the body's immune system. When the same drug is re-administered, it leads in eruption of drugs at a particular site. And with subsequent re-administration also, the drugs occur exactly at the same sites. So the commonest sites being lips, face, hands, feet, genitalia. And the single lesion, the differential diagnosis should be an insect bite reaction, or multiple lesions, it should be differentiated from erythema multiforme or Steven-Johnson syndrome. So this is our typical case of fixed drug eruption occur, where you see large molecule of black spots, again quite commonly seen in practice, where we tend to treat it for some post-inflammatory hyperpigmentation or a pigmentary disorder. So adverse drug reaction has to be monitored. So it has to be identified, and assessing casualty should be needed. Documentation of the drug should be done. Reporting of a serious drug should be reported to Pharmacovigilance Center, so that a lot of research happens on this. Thank you.
Yeah. Thank you, Doctor. It was a nice session. Before we conclude, we would like to open the floor for any questions you might have. Please feel free to type your questions in the chat and we'll do our best to answer them. Please drop your queries in the chat box. We'll read out and we'll answer the questions. Thank you, Dr. Saumajit. Dr. Nandakumar, I hope you have some queries. You can ask us, like, or you can just drop your question in the chat box. Doctor, we'll just wait for 2 minutes. If there are
Yes,
any
yes,
questions,
yes.
we'll move on. Wonderful presentation. Thank you, sir.
Thank you, Gagna. Hope I've made things crystal clear. But what I want to stress on this point is
Yeah.
drug reaction is not something uncommon. It does happen to all of us at some point of our practice, but
Mm.
we tend to overlook it. The
Okay.
only thing that I want to stress here is do not see any reactions very mildly. It could lead to life threatening disorders. When in doubt, always consult a specialist or refer to a higher center because here that we are dealing is with a life. So it matters too much to us. So handle with care.
So there are no questions. I feel like if there is any question, you can directly mail me, or like you'll be having my WhatsApp official number. Like you can just drop questions over there. We later we'll try to answer them over email. I'll just wait for it. Dr. Nandakumar, you can unmute yourself and ask your question. Dr. Prashant, thank you, sir. Okay.
Yeah, just to summarize, just to take some pearls home, as in takeaway messages,
Mm.
what I'd like to stress is whenever you give any drug, treat it as a potential threat. I've seen patients also react to commonest drug that is even your gastric tablets. So it's best you give everything under a caution. At least try to be safer on your end because these things with rising medical legal cases, a patient could any day come back and sue you for it. So when injections are given, always give it with a test dose, exercise caution, explain the patient the red flag signs or reactions that are expected.
Okay. Doctor,
I have a question.
Yes,
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 doctor.
Dr. Manas, please go ahead.
Sir, is there any update, recent update or files that we have to update it from the reactions?
Sir, there's no update. These are pretty common things that are happening. So this is all that is involved with severe adverse cutaneous reaction. And
Yes,
these
sir.
are the commonest thing. There's no offbeat that I've seen. And just as an inclusion, if you have to add, is only the COVID that is there. COVID also has got a couple of skin rashes in the similar pattern, like mobiliform rashes or denudation of skin. And when there is overlapping mucormycosis that is there, where it leads to falling of the ptosis or the falling of the eyeballs. Just that thing. Other than that, there's no nothing new with the disease.
Okay, sir. Thank you.
Thank you.
Thank you, Dr. Manas. Thank you for your question. Thank you, doctor, for answering it. Thank you, Prashant. I feel like there are no questions in the chat box. Okay. Yeah. Thank you all for joining us today. We hope you found this webinar informative and valuable. If you have any further questions or would like more information, please feel free to reach out to us. Additionally, we will be dropping a link in the chat box for you to fill out and submit to receive your certificate of participation. Don't forget to follow us on social media for updates on future webinars and events. Have a great evening.
Thank you, Gagana, and thank you all for your patient listening.
Thank you.
If there are any queries, if you have not understood or you want me to, in brief, give something, I'll definitely share my slide with Gagana. And also, I'll answer to all your queries. If there's something, drop in a personal mail to me or Gagana. I'll definitely do the needful.
Yeah.
Thank you all for being patient listeners.
Yeah.
Thank you, that's thank you, Gagana ma'am.
Thank you.
Thank
Thank
you,
you all.
Dr. Prashant. Thank you.
Thank you, Gagana.
Thank you, doctor. It was
I'll just close the session. Right.
sure. Thank you,
Thank
doctor.
you, sir. Thank you, madam.
Thank you.
Okay,
Thank
bye bye.
you.
Thank you.
Bye.
Bye.
We can leave, doctor.
Bye, ma'am. Bye, ma'am. Gagana ma'am.
Bye.
Okay.